I got a million questions I want to ask, but the one I wanted to focus in on is the bone marrow. Some of the rap against these new drugs is they seem to work well in the lymph nodes, eventually in the bloodstream, but maybe not so well in the bone marrow. Am I misunderstanding that? Are we just having a good enough time? What's going on in the marrow?
Yeah, that's a great question. I think that idea is in your mind, and many people are thinking along those lines. That's based on the fact that we really haven't examined systematically in the early studies how these drugs affect bone marrow disease. But indirectly, very early on, we already knew it's improving bone marrow function because patients typically lose their anemia, develop normal hemoglobin levels, platelet levels, recover, and that's a quick process, usually within 4 to 8 weeks. Using single-agent kinase inhibitor therapy. So we see that a lot if somebody's anemic, thrombocytopenic. Those numbers quickly recover, patients then start feeling better also pretty quickly. So indirectly, we have good indication to believe that the bone marrow is also cleared by the leukemia cells even early during treatment. But it is more difficult to measure and to analyze and to quantify. If you have lymph node disease, you can do analysis by imaging, study CT scans, analyze the volumes, and it's easier to quantitate. So these newer studies and some of my studies I've been doing with some of these agents, we sequentially look at density of bone marrow infiltration, trying to quantify that and put it side by side with these improvements in cytopenias. The underlying mechanism, like how CLL cells stick in the bone marrow versus lymph nodes, are kind of similar. They are relying on adhesion molecules, chemokine receptors, these tissue anchors. Those are different names for these tissue anchors I've been talking about. They are similar, so I think logically, if a drug mobilizes from the lymph nodes, it should do the same thing in the bone marrow. So I don't think there's a strong bias just clearing lymph nodes versus the bone marrow.
And do you have any of that data on the density, or is that too early to share at this point?
No, we haven't analyzed that. Okay. I know it from the patients I'm seeing,
right.
where I see usually slow improvements, but we haven't analyzed like whole cohorts.
So I know about these targeted therapies, these kinase inhibitors, blocking the communication pathways and blocking adhesion and homing. But talk to me a little bit about actual inducing lysis of the cells, actually killing the cancer cells, because I haven't heard much talk about that.
Right, it's difficult to model, and we've done, in my lab, we've done some studies to model that, but if you expose CLL cells in the right context, like in model systems where you have microenvironment, to these agents, there's not very much apoptosis or cell death. It's maybe accounting for 10 to 20% of the cells per day, and maybe that's enough and relevant for the in vivo situation, but it's clearly it's different from cytotoxic drugs where if you expose CLL cells to fludarabine, oftentimes you kill most of the cells very quickly. So it's probably a slower process. It is dependent on signaling. To see the best effects, you have to induce some activation, some signaling. It's more difficult to model, and the readout is different from cytotoxic drugs.
And is that why this drug seems to take longer to get you to a deep remission or a complete remission? It seems like it's usually the longer you've been off the FCR, the more likely the disease comes back. But with these, it seems like sometimes the longer you're on it, sometimes the deeper, the better you're doing. Is that the reason?
That's been systematically looked at, and that's really true for single-agent kinase inhibitor therapy. It takes 6 to 12 months, and the responses continue to get better. You have more partial remissions. Complete remissions on single agent are not so common, are rare, probably less than 10%. But the reason for that is that's certainly one aspect, that these agents are not classical cytotoxic drugs. They interfere with these signaling pathways, with the signaling that activates and makes CLL cells survive, but they're not so much destroying them quickly.
Okay. Let's pause for a minute and we'll continue in 1 sec.
Okay.